That's young, right?
Welcome everyone to the second annual RBNA Health Parkinson's Disease Symposium. For those of you who don't know me, my name is Megan Labor, and I am a physical therapist assistant with our therapy center and the Parkinson's Center operations specialist. I became very passionate about Parkinson's disease after my grandmother was diagnosed. Now I am blessed to live with her and help my family care for her, and I am very excited to be here today. I'm a little biased, but one of the greatest parts of RBNA Health Services is our Parkinson's Center. As Parkinson's Center leaders, we saw an unmet need in the community for people with Parkinson's to create this center. There is no better place to come with all of what RBNA Health has to offer, including our interprofessional team for comprehensive care. So our four main buckets of the Parkinson Center include therapy, exercise classes, education and community programming, and our PD Bootcamp. When we talk about therapy, this is not just physical therapy. We mean OT, speech, and in-home, outpatient. We are all certified by the Parkinson's Foundation to treat people with Parkinson's, in addition to LSVT Big and Loud. We all know exercise is the #1 thing to slow the progression of the disease. As a supplement to therapy, we have exercise classes, which you can try here today. Andrea is here teaching Balance and Beyond downstairs during our breakout session 1. And our new Dance for PD, which we just got a grant for, is being taught by Wendy, which you can also try today in either breakout session. There are more to come. We want to keep everyone informed with the most up-to-date research and information to provide to the Parkinson's Center community. Example of our community programming includes lectures from local movement disorder neurologists. We have support groups. We have a virtual support group on the second Monday of each month at 11 a.m. And that's for people with Parkinson's and or their care partners. And the last Wednesday of each month from 2 to 3 p.m. here at RBNA Health, we have a support group for people with Parkinson's separate from care partners. In addition,
Sometimes separate.
It was just the holidays, and an example of a social activity that we had was a sing-along. These are just a few examples, but to keep more informed with our calendar, you can look on our website or our upcoming event flyers. One of the highlights of the Parkinson Center that we have to offer, which Kate will explain more in detail to come, is PD Bootcamp. Our tentative date is March 31st. Kate said anybody wants to sign up. So before we get on to the rest of the speakers, let me just go through how the day is going to go. This is all in your program. Kate is going to be talking about lessons learned from Bootcamp, and then Dr. Buckingham is going to be talking about Parkinson's and dementia here on our main floor. There will be a break to speak with our wonderful sponsors, and you can head over to your breakout session. The breakout sessions for the first round are Dr. Connor in this main floor talking about future of deep brain stimulation. Dr. Chan is talking about hallucinations and Parkinson's. Can I just get a quick show of hands that are people interested in Dr. Chan's presentation? Okay, perfect. Just we rough count for chairs. And Dr. Tanaz is speaking about benefits of exercise in Parkinson's disease, and that will be on our 3rd floor, so you can follow the signs. People will be guiding around to each breakout session to lead you to the room. Can I get a hand count of people interested in going to that? Well, Andrea is downstairs in our learning lab teaching Balance and Beyond. We would love for you to participate, but if you would like to watch, that is totally fine too. Can I get a hand count of people interested in Balance and Beyond participation? 9. And Wendy is teaching dance for PD in our therapy center clinic. Can I just get a hands for dance?
So fun, guys.
It's so fun. But I know it's so tough to choose. There's all great options. Awesome. Okay, and then we will be breaking out for lunch, which will be in here. And then after 1:15, we will come to stay in here and have Dr. Mayton talk about future prospects of Parkinson's medications. And then from 1:45 to 2, dessert and coffee. We learned our lesson from last year. And then after that, we are going to break out for our last breakout session. Dr. Salvadori is talking about Parkinson's and pain management in the main floor here. Dr. Rathi is talking about adjunctive therapies with PD treatment in the family consult room. Can I just get a show of hands on who's interested in going to that?
Dr. Rathi?
Yes. Okay, perfect. Thank you. Amy Fetter, our social worker, is talking about discovering the role of a geriatric care manager in our 3rd level executive boardroom. Can I just get a number of hands? 10, perfect. Pam will be leading a meditation circle in our learning lab. Can I get his hands on learning? Perfect. And dance again, just in case if you're gonna miss it on the first round, you can hit it on breakout session number 2. It's gonna be a lot of fun. Anybody interested, raise your hand.
Oh, you're gonna need it by the end of the day. You're gonna want to
dance. Dance it out here.
You're gonna hear the music. You're gonna be drawn to it.
Yeah.
Don't worry. It's
Maybe
gonna
Ted will
call
sing
you.
for us.
Call out to you.
And at 2, and then we'll be wrapping up at around 2:30. Okay, so just for some housekeeping, there are some orange signs for directions of bathroom and elevator. But if you need assistance, find anybody with a purple lanyard or a green lanyard, and they will help you for direction. And just listen to the directions at the end of each main floor session to know where to go for your breakout session. Before we continue this symposium, I just want to mention we are so grateful for all of you that are both here and in person and virtually. We really appreciate our sponsors and couldn't do this without them. Please take some time to stop by their tables today and speak more with them. And at this time, I would like to give them a platform to tell you a little bit about what they do. So let's hear from Supernus.
Get up there.
Morning, how is everybody?
Good.
Thank you for being here today. My name is Travers Curtis. I work at Supernus Pharmaceuticals in the Parkinson's division. And we have 2 medications in the Parkinson's space. We have GoCovery and Apokyn. Both are adjunctive therapies to carbidopa-levodopa. GoCovery is the only medication that's proven to treat both dyskinesia and off time in Parkinson's. And then Apokyn is for acute off episodes. It's a subcutaneous injection that reverses 95% of off episodes. It can do it as quickly as 7.5 minutes, and 90% of patients have their best carbidopa-levodopa on within 20 minutes. So if you have any questions, I'll be over at the table. I'll be more than happy to answer any questions you guys have. Thank you.
And now we will hear from Farouk from Abbott.
Yeah. So my name is Farouk. We're here from Abbott, working with deep brain stimulation. So it's a implant that will help alleviate some of the symptoms of Parkinson's and essential tremor. And then I have my colleague Nia here as well, who can share a little bit about her personal experience.
Yes, so I'm Nia, and I also work with Abbott DBS with Farouk. My own mom has Parkinson's, and she had the DBS deep brain stimulator implanted about a year ago. And so I know, I'm very happy to speak on the patient perspective of that whole journey and also the caregiver perspective as well. So we'll be back there and very happy to have a chat.
Now we would like to hear from Acadia, John.
You want to try to bring it up?
Yeah, let's try. Hey, Mario, can you help me with the video?
Sorry, not used to that.
Yeah.
You could be here till tomorrow, sorry. See, Travers took up too much time, so I only can play a shorter video. I'm only here for comic relief. I don't even know why I'm here. Thank you. Don't hit me.
Yeah, why don't I go?
Yeah, go ahead. Go ahead.
Don't ask. Hi, everyone. I'm Saul. I'm with Medtronic. It's nice to meet you guys. Look, I've been in this role for over a decade. I've worked with people with Parkinson's disease for 13 years, every single day. And here's what I will tell you. It was asked, hey, who's interested in this? Who's interested in that? Some hands went up, some didn't. I will tell you, in order to live your best life today, tomorrow, 10 years from now, all the hands should be raised on everything. It's that serious. It's people who do take it that serious and do those things every single day in a decade, they're the ones who I'm like, wow, you look so good. And it's the ones who don't take it seriously and don't do those things every single day where I'm like, damn, that sucks. So I'm just being honest with you here. So when you get these opportunities, take them seriously and do everything. Okay? Thank you. Thank you. Hey.
How you doing? Well, you guys are staying here forever. So while he's gone, my name's John. I'm with Acadia Pharmaceuticals. We have Nuplazid, which is for Parkinson's disease, psychosis, and hallucinations. And what the video is going to show you is Ryan Reynolds, whose father had hallucinations and delusions associated with Parkinson's disease. And they talked about not only what Ryan and his brothers went through, but what the mother Tammy went through with caregiver burden. So we understand what the needs are, and we hope we can help you. If this ever becomes something that is an issue, please reach out to your physician. But since this isn't coming up, I'll tell you, you can go to moreparkinsons.com and you can go to moreparkinsons.com and the video will come up and it'll show you what Ryan and his family and his mom went through.
and just talk to your physician. If this is something that's happening to you, please bring it up to your physician. There is help out there. And we'd be very happy if we can help you as well. There's plenty of information at the table if you need it. So thank you for your time. I appreciate it.
Hi guys, I'm Stephanie. I'm with Amno Pharmaceuticals, and with some of the previous people, I've been working in the Parkinson's arena disease state for about 13, 14 years. I'm proud to be with Amno. We have an extensive line of Parkinson's treatments for varying issues, and we recently launched in September Crexont, which is the newest form of carbidopa levodopa, as you all know, is a cornerstone treatment for Parkinson's disease, showing benefits in less frequent dosing, longer periods of on time, and really addresses a lot of the abdominal gut issues that Parkinson's patients face very early on after diagnosis. Adjunctus, which is an adjunctive therapy. Dr. Rafi speaks for our company. He's one of the gentlemen speaking later, and we'll talk about add-on therapies and how they can be beneficial if you don't want to take more doses during the day of carbidopa levodopa, if you're experiencing off time. So there's just a lot of great information. We so appreciate you guys having us here. We love seeing all you guys turn out, and I hope you have a great day, get lots of information, and thank you for letting us support you.
I just have some.
They're trying to get us without
Yeah. Yeah, when I got it, yeah.
Oh, yeah.
So.
I know that boot camp might be a little scary in terms, but it is, it's intense. There's a lot of education. There's a lot of topics to cover. There's a lot of exercise because if you're going to come to a program led by physical therapists, you betcha we're going to get you moving, right? So I know people think boot camp like, oh, this sounds scary, but I want you to know that it is not. Megan introduced what the program is. We take up to 10 people. It's 8 weeks and it's twice a week. 1 week, 1 day is education and twice is exercise. And we go through a workbook so you can document your journey. And we go through all sorts of topics, many of them that you'll hear about today. But when you sit here, and I commend you for being here and reading your research and sitting through a lecture, but it's still hard to say, does that really apply to me? Wait, salmon's important, but I don't like salmon, or exercise, but my arthritis, I'll skip that one. No. So through boot camp, we can say yes, but, or and despite, and we can make an individualized program for education and for exercise. We hit them all. So according to the American College of Sports Medicine and Parkinson's Foundation, there is a recommendation for Parkinson's and exercise. How much you need for cardiovascular and endurance training, strength training, flexibility, cognitive balance. And we want you to hit all of those buckets. But if you did it on your own, you might think like, I'm going to exercise all day long. I don't want to do that. So we want to try to find ways that we can hit 2 things for the price of 1. Yoga, we're getting flexibility and balance. HIIT training, we're getting some cognitive dual test, balance, endurance, everything wrapped in. I love 2-for-1 specials. So any way we can get it all done in a shorter amount of time, that's better. But also, we want to expose everyone to the different variety of exercise because we want to find the best one. What is the best exercise for Parkinson's?
And the one you like.
The one you like, the one you do. Dopamine, baby, right? If you like it and it makes you happy, that helps too. But if you like it, you'll do it. If I had a magic pill and it was too big to swallow, it does no one any good. You have to swallow the pill for it to work. You have to do the work to get better, right? Another fun one we do, how to fall safely, is a really fun one. So we polled our participants with surveys and we said, hey, what did you get out of this? We know what we got out of it. And you can see, oh, I'm so happy that exercise came up really big. But look at connection, support, engagement, community. We didn't plan on this. These were the unexpected lessons that we learned from our participants. Of course, as scientists, we take baselines and then we do an intervention and we measure. We need to make sure our program works because why have it if it doesn't work? We tested all of these different elements and can you guess what happened? They got better. That's the power of exercise. But there's other things that we tested like efficacy, the belief in your ability to manage your disease. It went up just by education and support. Another one is the Pro-PD score, which is a great tool to help measure and get a baseline of where you are. It's online and it measures all sorts of elements, not just the physicality or cognitive or it's motor and non-motor symptoms. And it's a great baseline to see kind of where you are compared to others with many years of diagnosis and to share with your physician. So that's the science. But we took away a lot of other things. One is learning in a group has a value that we didn't expect. Having individual sessions, yes, we can make the program more tailored to them, but sometimes saying, no, you need to do this, but someone else hearing it says, oh, well, that's a good idea. Or I was there, I did that too. Or maybe I don't need that yet, but I might need it in the future. So there's definitely value in the group. We talk about difficult things because it's boot camp and we're going to do it. If I have you in a room, I'm going to nail you down and we're going to talk about end of life planning because it has to be said. We're going to talk about pelvic health. We're going to talk about incontinence. The intimacy topic was probably the most fun, but we've learned we have to do it in the right way with sensitive material. And I think going through that experience together also creates more of a bond. Early, you are in charge of your journey. We're here to help, but we noticed those who took charge and did boot camp early in their diagnosis got a very great benefit. And group exercise, There's something about the social connection, that feeling like, no man left behind. Come on, you got it. I think it enhances people's performance. Maybe there's a little competitive edge or intensity tolerance. Maybe you can handle a little harder than you think when you're in a group and they're doing it too. And we just want to get rid of all these myths and stigma. I'm sure you remember when you got diagnosed. What did you feel like? Oh, Parkinson's? Who did you think of? Did you think of Michael J. Fox?
Sure.
But what if we shared, and this is a soapbox that you can go on forever, but what if we shared it early when you don't know, when you can hide it? Because then that will be the norm. When people think of Parkinson's, they think normal, not tons of dyskinesias, right? So people coming into bootcamp and support groups, like, I don't want to see my future. I don't want that. But then when they come and they say, oh, young, healthy, active, smart, funny, and you come away with friends, we can dispel those stigmas and myths. And then again, the community. I'm going to skip this for now. I want to have a couple of our alumni who have prepared a little bit to talk about what they got out of it. So Miles, since you're right here, do you want to start? You want to stand up and face the crowd? These are our 3 cohorts. The first one was sponsored by the APDA. Thanks to our grant, we got it off the ground. And then since then, we've had 2 more sessions. So Miles, tell us.
Well, as the voice in my head says, stand up. It's Kate's voice. Sometimes Megan's too. But anyway, my name is Miles Turpin, and I got diagnosed in 2016. And at first, I really thought the doctor was kidding. I just thought, my mother had it. And I just remember her at the very end when she couldn't move and do anything at all. I didn't have that. You know, my wife was just telling me that I had a little twitch in my hand and that my gait was wrong. And we could go through the grocery shopping. She'd go, stop dragging your feet. It's like, what is her problem? Leave me alone. But finally, it became very clear through a lot of falling in the bushes and things like that I had Parkinson's. And then I got this thing, I don't know why me, but everybody has it differently. My thing is my back, as you can see. And I used to be like this. And I was so far down that when I went to the doctor's appointments, I had to have somebody go with me because I couldn't see the numbers on the doors. My head didn't go that high. And so once I got really serious and it really started to hurt every day, all day long, I took this seriously. And this was when boot camp came about. And, you know, I came into boot camp and everybody's in a different place. And I was probably, you know, experiencing more symptoms than most. And there was a real opportunity for me to just go, you're different. Why don't you just go crawl in the corner and die? You know, and because that's what my brain does. You know, I just take the negative side every time. Just a little thought that pops in. Well, I don't know who creates those little thoughts, but I wish they'd get out of my head. And the boot camp has been doing that for me. Because when we did it all, everybody is at different places on the things that they give you, you know, whether it's Tai Chi or strengthening or dance, you know, you do it at your own pace, but you do it. And it's inspiring to see other people succeed and change, you know, because it just becomes a fact of life. It's like, I am part of this community, and in this community, we change and get better. It's not like, you know, a life sentence, because you're feeling that things are getting better every day. And that sense of community is, for me, what makes everything work. It's all a theory when it's between my ears, but when I actually do an action, something changes. And when I do an action with the same people every week, something changes and it gets personal, and I want to see them and find out what's going on with them. So it's been really good for me. I'll be quiet.
Thank you.
I'm Craig Borders. I was in the second, I think it was the second boot camp class. I'm a semi-retired medical writer. And so I've seen a lot of medical materials and been to a lot of medical meetings. So I'm not easily impressed with this kind of thing, but I was very impressed with boot camp. As Kate's described and as Miles has described, you'll learn a lot. And it's not just learning and doing, it's the community of, you know, interacting with other people who have the same issues. Actually, they don't always have the same issues, and that's what's interesting. Someone may have an issue that you don't have, but you've got an issue that someone else has. And you learn from people and you understand, you know, we're on different parts of this so-called journey. The program is really rigorous. I think as Kate alluded to, it's twice a week. Ours was Monday and Thursday. You mentioned that you call them lectures. I would actually call them seminars because it's very small group sessions on Mondays. You have homework. And if you can hold up our, just want to show we get a textbook. This is a textbook, chapters written by experts in Parkinson's disease. And then Kate referred to the workbook. This is something that developed by the RBNA, and this is very impressive too. And then in terms of the schedule, Kate alluded to some of them, but you do high intensity exercise programs, you do cardio, strength exercises, and then the seminars. You have things like on medical management, cardio, mental health. We did some Tai Chi, we did some boxing, which was fun. My neurologist told me I should do boxing first. I thought he was nuts. I said, I'll get a concussion. What are you talking about? But you do boxing here, you're not going to get a concussion. But it's a very good form of exercise if you have Parkinson's disease. Kate asked, what did we learn? What was the single most important thing we learned in boot camp? There were so many things, I can't think of one, but the one thing was not actually directly in the curriculum. That is, people with Parkinson's are the nicest people you'll ever meet.
That's awesome.
Thank you.
Andrew, can you all, Ted, do you want to speak, right? Andrew, where are you? Yeah, come on up, and Rick, come on up. That way we can go just quick. Your 30-second elevator speech. You got it. And I hope you noticed the t-shirt. So every cohort has a different shirt. Please find them, ask them questions about the program.
My shirt's purple if anyone wants to know. Sorry.
Hold it really close.
My name is Ted Seibert. I was diagnosed about 2 years ago now at this point. And when you get that, when you get the word that you got it, or you have this, it really changes your life, and because you're just now thinking, well, how long is this going to go on, and what I'm going to do, and what it's going to be miserable, and why do I want to go through it? But RVNA and getting into this proper group was life changing, and you've heard a lot from others here already of what it's like. I just want to say that we had 8 people, I think, in the group. I have 8 wonderful friends that I've met here, and it's just a wonderful thing.
Thank you.
Hi there, I'm Andrew Doherty. So this time last year, I think my only exposure to Parkinson's was I had my uncle, and he had a very noticeable tremor, but I knew nothing about the disease. And I suppose 4 months later, I myself was diagnosed with Parkinson's, so just last May. So I feel like I made a couple of good decisions since then, and the first being to do LSVT at RVNA. So I was kind of very lucky to find RVNA. And then the second good decision was to actually sign up for Bootcamp. Even though I was kind of working full time, I was like, no, I need to take time out and focus on taking care of myself. So one of the things that I really valued from the Bootcamp was actually listening to and learning from other people who had Parkinson's, maybe diagnosed earlier than me or diagnosed much the same time as me, what they're experiencing, how they're feeling. But certainly I would say, more than the Bootcamp, the day that I actually came to RBNA, I felt like I was starting to build that support network that I think we all need to kind of manage the disease. So thank you.
Hi, I'm Rick DePiero, and I never met anybody with Parkinson's before. And when they diagnosed me, it gets about 5 years ago, they diagnosed me incorrectly. And then 2 years ago, my wife found the doctor that I went to and then I was diagnosed. But anyway, by going to the group, it was amazing because it gave us an opportunity, or gave me an opportunity, to meet other people. First thing you do when you get Parkinson's is you go on the computer and you look at everything that could kill you. All you do is like, this is going to happen, that's going to happen, this is going to happen. And then my wife, as you know, thank God I have her. She says, you have one more day and then start doing something about it. And I found you guys. Yeah.
Thank you so much for sharing. And I just wanted to say thank you to our participants for your feedback. Thank you for our speakers. Thank you to Andrew and Megan for teaching an amazing program. And Bootcamp is still continuing to evolve and change based on the needs. We want to hear from you, and then we take the research and put it all together. So if you are interested in the program starting in the end of May, we will have you out before Memorial Day. Please find us at our table in the back. Thank you. Okay, I would like to call up Dr. Buckingham. If you need to stand and take a stretch, you can. We just saw each other, no mask today. You have present your view. You don't need any notes. Oh, you're good. Let's just check. Okay. Thank you. Wait, that works. Okay. Okay. Can everybody hear me okay? Okay. So I'm happy to be here. Thanks for inviting me. Dr. Buckingham, I am a movement disorder neurologist with Stanford Health. And I was here last year presenting, and I'm happy to be invited back. It's a great event, and it definitely looks like more people this year than last year, which is always great. So this talk will be about dementia related to Parkinson's. So it's a pretty comprehensive topic. We have about 20 minutes to go over this. So it'll be generally pretty broad, but then there'll be some time for questions afterwards. Okay, so we will go through terminology definitions, risk factors for developing dementia and Parkinson's, statistics, the pathophysiology, what are some of the common cognitive changes we see in Parkinson's, what sort of testing, if any, do we end up possibly doing, what are the options, treatment, and sort of going along with treatment, just generally what kind of risk reduction can we engage in to sort of prevent this from happening. So the terminology, this is sort of general, right? As everybody's aging, of course, our memory changes, our cognition changes, and there are certain changes for the general population that we would consider to be normal. Your normal aging, age-related memory changes, maybe having some word finding difficulty, maybe not being able to quickly pull up the name of an actor, walking into a room, not remembering why you're there, although I do that too. Those kinds of things that most people encounter as they age, and those we don't worry too much about. We do monitor them, but it's not something that is typically alarming. The next term that we will sometimes use is called mild cognitive impairment, and that's generally the phase that's kind of in between what we would consider to be normal for your age versus dementia.
So it's those people who have some cognitive changes, and I'll be kind of specific about those in a few slides, that are more than what we would expect for your age. However, they're not actually impacting your day-to-day, right? You're still independent, you're driving, you're carrying out your usual tasks, but there are some changes that are probably more than what we would expect for age. And then the more advanced category we would call dementia. So dementia is, again, this is not even specific to Parkinson's, but in general, it's a chronic process, and it's a progressive change in your functioning, loss of your cognitive functioning, which does start to impact your day-to-day tasks. Sometimes getting to the point where it's sort of impacting your independence. So that's sort of the borderline between the MCI, which is a mild cognitive impairment, and dementia. Dementia itself is really a descriptor term. So just like Parkinsonism is a descriptor, right? There's all different types and causes of Parkinsonism. There are different types of dementia. So we do try to be specific with what type of dementia somebody has in general. For the general population, these are the types that we most often encounter. Alzheimer's disease for the general population is by far the most common. There are other types, frontotemporal dementia. Within the Parkinson's world, we're really looking at the bottom three, which is Parkinson's disease dementia, dementia with Lewy bodies, and then vascular dementia. And vascular dementia, we're really not going to talk about today, but that's for patients who have vascular Parkinson's disease, who then also have a risk of getting vascular dementia. So that's sort of a separate category. We'll mainly be talking about Parkinson's disease dementia and then dementia with Lewy body. So what are risk factors for dementia? So for the general population, not really talking specifically about Parkinson's, it's really age, your family history, and your what we would call vascular risk factors. So those are things like blood pressure, cholesterol, diabetes, smoking, sleep apnea. Those do generally apply to the Parkinson's population, but specifically studies have found these other risk factors that are specific within the Parkinson's population. And that is also age. So just generally being older with Parkinson's, specifically an older age at disease onset. So the older you are when you're actually diagnosed with the disease, the more likely you are to get dementia. So as an example, somebody who's diagnosed in their 80s has a higher chance of later developing dementia compared to somebody who's diagnosed in their 40s or 50s. So the age is definitely part of it, and it's a strong risk factor. In general, greater disease severity. Specifically, they found that, excuse me, those patients who have postural instability, gait disorder subtype, just meaning a lot of issues with mobility, a lot of falls, injuries, complications from that, tend to have a higher risk of developing dementia. Some studies have shown that having REM sleep behavior disorder is a risk factor for developing dementia. Having any psychiatric symptoms, meaning hallucinations, paranoia, depression, all of those can also impact your cognition and increase that risk. And then male sex and lower education level. That slide kind of going along with this one, at the bottom here, you'll see the studies of Parkinson's and dementia are really, really variable. So some studies look at the entire population of Parkinson's as a whole and sort of draw statistics from that and draw out, evidence for risk factors. As we all know, everybody with Parkinson's is very different. So we sort of have to take all of this with a grain of salt, because some studies are looking at all type of everybody with Parkinson's, right? And everybody's very different. Some studies look only at younger patients, older patients. So these that I have pulled are generally from more recent studies. So we'll kind of go through these statistics, but just keeping in mind that there's just so much variability. So in general, the risk of dementia, it's 3.2 times greater if you have Parkinson's than if you don't. Patients, again, who are older, so patients older than 80 years old, their annual risk of developing dementia is about 8%, versus patients who are younger than 70, that risk drops quite a bit with an annual risk of developing dementia at about 2.5%. If we take all Parkinson's patients, and again, these statistics are not necessarily consistent from study to study, but it's felt like all comers, the risk of dementia 5 years after you've been diagnosed is anywhere from 3 to 12%. Again, if you're diagnosed at age 85, by the time you're 90, as you can imagine, right, it's possible that you have already developed dementia, but that's very different from somebody who's 55, diagnosed and they're 60, much less likely to develop dementia, of course, at that age. And you can just kind of go down the list, at year 10, a very wide range, anywhere from 9 to 27%. And again, that probably comes back to the ages, right? That's really a strong factor. But there is also data out there that says probably the risk of developing dementia 25 years after you've been diagnosed is very high. Again, another asterisk. Consistently across study to study, it has shown that patients who are young onset Parkinson's, meaning less than 50 years old, have a very consistent low level of dementia, even if they've had Parkinson's for many years, which is kind of interesting. Pathophysiology, not necessarily different from actual Parkinson's disease. So we're talking about the alpha-synuclein, the accumulation of that specific protein. And these are sort of thought of as a spectrum. So there's Parkinson's disease. There's then the PDMCI, which is the Parkinson's mild cognitive impairment. The PDD, which is the Parkinson's disease dementia. And then the DLB, which is the dementia with Lewy body. So these are sort of viewed as a spectrum in the sense that the alpha-synuclein is sort of the root cause of these, and it's really a function of the alpha-synuclein spreading throughout the system. And this could probably be a whole separate talk about how it spreads, right? In this bottom section here, we now include the gut, right, as part of this potential kind of pathway of the alpha-synuclein, because we know now that the gut is probably involved. But the bottom line is that the alpha-synuclein spreads, particularly to cortical areas, and it does start to cause these cognitive changes. So specifically in Parkinson's, what are we really talking about? So let me just jump to this one. So most of the time when we're talking to patients, they'll say, oh, my memory is starting to change. Sort of using memory, and what they really need is cognition. So memory is actually just one part of cognition. So we think of cognition as various domains. So there's attention and focus and concentration. That's one part of our cognition. There's language. There's executive function, which we'll get a little bit more into. Perceptual, motor, visual, spatial, social cognition, and then learning and actual memory, short-term memory, long-term memory, immediate short-term memory. So there's actually all these different parts of cognition, not just memory. And there's different patterns of weaknesses within these domains that would support somebody having Alzheimer's versus somebody having Parkinson's dementia. They're actually quite different. So in Parkinson's itself, some of the common changes that we see, and these can be changes that we see sometimes even in the very beginning of somebody's disease course, or maybe even a few years in, and they can be very subtle and mild, but they're commonly present. And they are a impairment of executive functioning. So executive functioning is being cognitively flexible, being able to multitask, to organize, to plan, to initiate tasks and kind of carry them out. So in Parkinson's, we do often see changes, particularly with multitasking, being able to be cognitively flexible, right? You're working on a task, somebody interrupts you, you have a conversation with them, being able to quickly go back to that task is often difficult. We see changes with attention. So just being able to, right, attend to something, concentrate, focus, finish it without getting distracted. We can sometimes see slowed processing. So I would say this is something clinically that is we see quite often. And what that really means is I always think of it as, of course, we know with Parkinson's, the motor symptoms, right? You become physically slow, right? You're not moving as quickly, as fast as you used to be able to do. And that can happen cognitively as well. So being able to quickly, pull out what you're trying to recall, right? Manipulate it and express it, that whole process can become slow. Not necessarily that you've lost your memory and you're losing things. It's just to be able to get it out and process it and express it takes longer. So that I would say is fairly common. And then as with motor symptoms, there can just be a lot of fluctuation, right? Some days you feel very sharp, lucid, everything's normal. The next day you're just feeling kind of slow, you're getting distracted. That variability is also very common, just like with the physical symptoms. That one, okay. And then getting back again to like how we think about the levels of changes. So again, we can see mild changes, we can see sort of age-related changes. Again, so there's some slowing of the processing, maybe a little bit of executive dysfunction, but still what we would consider to be maybe expected for Parkinson's. So that's sort of very mild category. That's sort of one level. Again, the next level up from that, this would be meaning, right, mild cognitive impairment. We're seeing those changes more frequently, maybe more severely, maybe other people are starting to notice it, that type of thing. However, still, functioning well, doing, taking care of yourself, driving, all that kind of stuff. And then, of course, going one step further and seeing changes that are now really impacting your life, right? Impacting your day-to-day, your ability to keep your calendar, stay on task, do your finances, that type of thing. Once we do get to this point where we would label something as a dementia, you can start to see actual memory loss. So going back to these domains, typically with Parkinson's, it's the attention can be affected, the executive functioning. Once you get to a point where we're saying, okay, I think maybe we've crossed over into that mild dementia category, we can start to see things like actual short-term memory loss, forgetting conversations, repeating yourself, that type of thing, maybe a little bit more language involvement. And once we get to that point, that's really when we're saying, okay, are we in the category of Parkinson's disease, dementia, or Lewy body? Those are pretty much the two categories that we're looking at. And again, they both get to a level where they are impacting your day-to-day life. However, it's important to distinguish between the two because as you'll see with Lewy body, we are sort of screening for other symptoms that might come up. Sometimes Lewy body is a little bit of a faster decline. So how do we really determine which category somebody is in? So PDD, the Parkinson's disease dementia, the criteria delineating this from Lewy body. One of the criteria is the timeline. So did the cognitive changes begin at the same time as your physical changes did, your motor symptoms? Did they occur before the motor symptoms began or after? So Parkinson's disease dementia is really defined as the cognitive changes clearly began after the onset of your motor symptoms. So you're somebody who's diagnosed with idiopathic Parkinson's disease with motor symptoms, and then at least a year later, we start to notice that the cognition is changing. So there's a definite sort of gap in between when these two sets of symptoms begin. And PDD is generally a slow decline, similar to the motor symptoms, a slow decline. There's typically nothing particularly rapid about it, unless, as we all know, right, with Parkinson's, anytime you're ill, you have surgery, or in the hospital, you have anesthesia, things can get worse quicker. But the actual brain processes and progression is fairly slow in the PDD. And that is in contrast to Lewy body. And Lewy body is when the cognitive changes begin either before the physical changes began or around the same time. So there's not that gap in between when the motor symptoms started and then when the dementia or the cognitive changes began. The other important feature is hallucinations. So with Lewy body, we certainly see hallucinations. You can also generally see that in Parkinson's disease itself, but with the Lewy body, they're certainly more prominent. And another feature that we will sometimes see is kind of more extreme fluctuations in the cognition. So not necessarily these good days, bad days, but more extreme than that. And that we will sometimes see more with Lewy body. And then, like I said earlier, sometimes a little bit more of a rapid course, unfortunately, where patients get worse a little bit faster. So the testing we have available, and we don't do this for every patient. You know, if it's a patient who they've had Parkinson's for 10 years, very slowly, they're starting to show signs of cognitive change, unless there's sort of an unusual feature or things are changing very quickly, we typically don't do a lot of testing. Maybe we'll do the blood work. The blood work related to cognition is typically vitamin levels and thyroid, making sure those are normal. But some of these other testings we may not do. But for patients where maybe there is an unusual feature to the cognitive change or it is coming on pretty quickly, we may do an MRI of the brain to make sure that they don't have a stroke or some other structural issue happening. The third one down, the neuropsychological testing, usually encourage patients to do. And some of you, I'm sure, have probably had it done in this audience here. It's more extensive cognitive testing. So it's about 2, 3, 4 hours of cognitive testing. And it's helpful, you know, of course, for a diagnosis, although, you know, we clinically typically aren't too surprised by what we're seeing. We're not looking for other, you know, sort of rare diagnoses. But it's helpful to pinpoint what parts of the cognition of those domains, like what parts are weak. Because for most people, a lot of their domains are actually normal, but like we've talked about, maybe 1 or 2 are weaker, right? And like, what can we detect that's not normal and how can we sort of have a targeted way to fix it? And it's also something, the neuropsychological testing, that we will sometimes use to track over time. So we'll have somebody get it done and then maybe a few years later repeat it, compare it, and see what might have changed. And then the last one I would say I very rarely do, but we'll sometimes do a PET scan, which looks like the actual brain activity. That's not common, but sometimes we'll employ that test.
Yeah.
And then treatment. So similar to treating the motor symptoms of Parkinson's, there's sort of different branches of treatment, medications, of course, therapy, and then lifestyle. So the medications we have available for memory are these 3 that are listed. They are old. They were developed for Alzheimer's originally. The top one in particular, the rivastigmine, has been studied more and more for Parkinson's related cognitive changes. And that's the one that we tend to use, at least I tend to use first. I think it has the best evidence for helping cognitive changes in Parkinson's. But I think anecdotally, I think it does help. I think most patients feel maybe their processing is a little faster. They just feel a little bit brighter. Generally, very few side effects. If you do get them, they're GI related. Sometimes even it causes loose stool. So if you're constipated, that's helpful. Comes as a patch, which sometimes is also nice instead of taking another pill. Does also come as a pill. So that's one option that we'll sometimes use. And actually the last thing about it, sometimes it helps with hallucinations. So it probably has a little mild benefit for that. Donepezil, which is Aricept, and then memantine, which is Namenda. Those are more traditionally used for Alzheimer's, but we certainly also use them in Parkinson's. And then the other point about medications, anybody where the cognition is changing, we always do a check of the med list, right? Because we know there's medications that can make your memory worse, that can make your cognition worse. So they tend to be in a specific category of medication that we call anticholinergic. So that's things like amantadine or trihexyphenidyl or artane. And a few different types of bladder medications. So there's certain medications that, while they work really well for urinary frequency, they actually can also affect your cognition. So it depends on the case, but sometimes, we'll look at the med list and maybe lower, discontinue a medication if we think it might be contributing. Cognitive therapy, so that's like a speech therapist. I think it's typically helpful. So it's like doing physical therapy, but it's for the cognition. So that's usually pretty helpful. And then this is maybe the most important, which a lot of this applies to Parkinson's itself, but a lot of trying to help your memory and your cognition improve, trying to even reduce the chances that you will develop cognitive changes as time goes on. A lot of it is your lifestyle, really. Sleeping well, exercising, of course, for other reasons related to Parkinson's too. Eating well, probably some evidence for Mediterranean diet, drinking enough water, and stimulating your brain. Like it really is helpful. And that's even just as you're aging without Parkinson's, just right. But thinking of healthy aging, a lot of it is being stimulated. So like Kate was saying, right, going to these exercise classes, right, coming here and socializing. I have patients where even I can get them to just leave the house every day, even if it's just to go to the store, walk around, go to the library, listen to a lecture, just anything where you're stimulating, right? You're getting out and you're interacting and having new experiences. We know that helps. So that's important. And then any sort of games, puzzles, even if it seems silly, just again, anything that stimulates your brain in a different way is helpful. Which sort of segues into risk reduction. Again, exercise. And this also goes for the general population. We know that aerobic exercise reduces everybody's chance of developing anything neurodegenerative, whether it's Parkinson's, Lewy body dementia, Alzheimer's. Very important, right? Managing vascular risk factors, trying to control the things we do have control over, right? So any high blood pressure, diabetes, high cholesterol, making sure that you work with your primary care doctor to manage those as best we can, because we know that if they're not well managed, they also increase your risk of developing cognitive changes. OSA is sleep apnea. So, a point about that I will make is that we know that Parkinson's patients get tired, right? Fatigue is a really common symptom. But what I would say lately, I've been noticing more and more is I've actually been sending patients more to get sleep studies. And a lot of them end up having sleep apnea, right? Which we also know causes fatigue, but it also is a risk factor for developing dementia. So something to think about, because, there's some things in this general treatment that we can't control, but there's some things that we can, right? And if there's any way we can intervene to try to reduce, risk of developing either worsening Parkinson's or dementia itself, it's worth doing. And then there's some studies that have shown actually that the last part, orthostasis, right, having your blood pressure be too low or blood pressure fluctuating, which we do see a lot in Parkinson's, that actually patients have a less risk of developing dementia if that orthostasis is well controlled, which is kind of interesting. That was just something else that came out of the studies that I looked at. Okay, so summary. So we do see, we went through some cognitive changes we almost expect, but at a very, very mild level. And that's a lot of times related to attention, to processing, to being able to multitask and be flexible. So those changes we see, and they don't always get worse, right? But sometimes they do, and that's sort of why we keep track of them and monitor them. And again, we have the levels of cognitive changes, the common, mild changes, the MCI, and then the 2 types of dementias. And then again, there are some medications, there's cognitive therapy, but honestly, cognitive hygiene, meaning your lifestyle and sort of your day-to-day and how you structure your day, is really important, and it really makes a big difference. We know that with the physical symptoms, but it also makes a difference with cognitive symptoms and preventing, or at least reducing, the chances that we do develop cognitive changes as we age. Well, complex topic. Hopefully we got some pearls out of that, but it's, like I said, and I think it's just very interesting that the studies that look at Parkinson's and dementia and cognitive changes, they're so heterogeneous. There's just so many different variables that impact, what we think about as cognitive changes, but also just the numbers that are cited. So any questions?
So a lot of the symptoms, cognitive symptoms you described sound a lot like ADHD. I've had it all my life and was diagnosed about 10 years ago. Now, two questions about that. I'm always looking to see if there's any connection between ADHD and PD. The other question is, could the medications that help you with symptoms of ADHD help with Parkinson's or not, because they're different parts of the brain? You have to do ADHD in the front and PD in the back. So any connection, and can you use the ADHD medication?
Yeah, those are great questions. He's asking about, excuse me, any connection between Parkinson's and ADD or ADHD, because of course that obviously has to do with difficulty with attention. And do any of the ADHD medications help with Parkinson's? I would say I'm not aware of a direct connection. I will say that brings up the point that sometimes when we have patients go through the neuropsych testing, the memory testing, sometimes out of that testing, we do see that there's evidence of ADHD that was just sometimes never previously diagnosed, right? But that test is very sensitive for picking up neurological and, psychiatric diagnoses. So sometimes we do see that. I would say that there are patients with Parkinson's where we do use the ADHD medications. I would say myself, it's almost more for the fatigue aspect, but that's actually a very good point. I think I would say anecdotally, it does help with the attention aspect, even though it is probably different parts of the brain. But we do run across that sometimes. And I think for, let's say, the patients who are now in their, 50s, 60s, 70s, ADD, ADHD weren't often recognized in your childhood. Right now, they're diagnosed more readily, but I think there's probably a lot of people in that age group who do actually have those diagnoses and they're just not recognized. But like I said, I would say maybe a few times a year, the outcome of that neuropsych test is like a new diagnosis of ADD or ADHD.
And I wonder if there's misdiagnosis between the two.
Yeah, maybe. I mean, that testing is pretty sensitive for teasing apart, right? Having an actual cognitive impairment from Parkinson's versus the ADHD. But that's a good question, because there's probably, I don't know for sure, but there might be some relationship. But I think it's been hard to study because so many adults now probably do have it, but it was never diagnosed. Yeah.
Thanks.
Hi, thank you for being here. I'm a 77-year-old who was diagnosed in November. And what's been happening is I had incredible swings in blood pressure. It was very high and then very low, to the point where it disrupts me all day long, because I do check it and I can tell when it's happening. You're very lightheaded and ready to faint. Is that, I see you had that up there with the word that I can't pronounce.
Right, the lithostasis, right?
Right.
Yeah.
I'm on propanol, 120 milligrams, and there is mention in that about affecting blood pressure.
Right. Yeah, so I would just say that I think the note about the blood pressure is the fact that for patients who do have either very low or just the extreme fluctuations, it can affect, how do I even phrase it? Like your brain homeostasis, right? Almost like when you get a UTI and it makes everything worse. Your brain is just seeing such fluctuations in the blood pressure that it does disrupt functioning. I guess I think of it that way. But I would say those patients who do fluctuate like that, it's hard to control. It's very challenging to figure out what sort of combination of medications keep you the most level. But I would say that, at some point, most patients find some regimen that helps a lot, but it just takes time. But the more we can sort of keep the brain from seeing extremes one way or the other, I think it helps in the long run.
Thank you. Could you talk a little more about this exchange between the brain and the gut, or what is that? Is there any chance for intervention there? And then just secondly,
Yes.
we're all bombarded by Prevagen commercials. Is there any there?
I mean, Prevagen is right. There's of course, right, the Prevagen or Nariva, I think is another one. I mean, they just haven't been proven. They just haven't been studied the way that pharmaceuticals are studied. I mean, have I ever seen a side effect from it? I don't think so. It's really just the cost, right? It is heavily marketed, of course. And I've had patients take it for long term, and I have not really seen it make that much of a difference. But the studies of it are just not as rigorous, I guess. But I'm not sure there's that much of a downside except for the cost. Yeah, I'll go back. Let me go back. Oh, here. So yeah, basically, what we found, this is very cursory, this could again probably be another like 2 hours of discussion, is that in the right, like in our guts, like they found alpha-synuclein, right? So the same right protein that's abnormally accumulating in the brain, it is also in the gut. And there, the thought initially was maybe it's, somehow because of the change in the gut biome and the bacterial colonization, it starts forming and then it spreads upwards to the brain. But there's some thought that for some patients, maybe it actually begins to accumulate in the brain first and then goes down. And I think that the research is trying to really figure out, as I said earlier, right, every patient is different, right? But is there some way that we can at least, we do subcategorize a little bit now clinically, but there must be something we're missing, right? Because so many patients are very different, although there's probably just more subcategories that we're not recognizing yet. And also, does that somehow relate to how the alpha-synuclein is spreading, right? And there's some thoughts that if it spreads from your brain first and then goes to the gut, those people have different symptoms than if it goes from the gut to the brain. So it's a very active area of research. I mean, they're also studying probiotics, and if there's specific probiotics that will sort of normalize the gut biome and pathology and perhaps reduce the spread of the alpha-synuclein. So it's very interesting, right? Because we know people get constipated, but we never quite realize that, right? That same protein that's in your brain is actually also in the gut. Thank you so much, Dr. Buckingham. For the best interest of time, let's go into our breakout sessions. So if you are interested in hearing Dr. Connor in the future of deep brain stimulation, you will be staying here. If you are interested in hearing Dr. Chan about hallucinations and Parkinson's, you will be